Good evening. This is Dr. John Bennett. We're sorry for the late start. We had some technical difficulties. Um, Tonight we have a hangout in the continuing series of Parkinsonism education hangouts with world-renowned neurologist Dr. Abdul Rana from Toronto, Canada. And tonight, Dr. Rana is going to be talking about progressive supranuclear palsy mimicking Parkinsonism. Good evening, Dr. Rana.
Good evening, Dr. Bennett.
I'm glad you're still here. Okay, we'll get to this because I know it's a big topic and you want to cover it, and I want to learn what really it's all about. So let's start with the questions. How common is progressive supranuclear palsy?
Progressive supranuclear palsy is a rare condition. The exact incidence or prevalence is difficult to determine because of several factors. One is that sometimes this condition could be lumped with idiopathic Parkinson's disease or other types of Parkinsonism. And in some cases, the lifespan is short and the detection of this condition may not take place early on. Some reports suggest about 1 to 2 individuals in a population of 100,000. So it is a rare disease. The interval from the initial symptom onset and to the diagnosis could be a few years, and then usually the survival after diagnosis is only up to 2 to 6 years. It is a sporadic condition, and some of the reports have suggested a autosomal dominant inheritance pattern as well. The progressive supranuclear palsy is considered a second most common cause of Parkinsonism. And usually the median age at the onset is around 60 to 63 years.
What is the common presentation of progressive supranuclear palsy?
Most of the patients present with early onset of falls. They have postural instability, they have cognitive issues, and they have a vertical gaze palsy as well. So the earliest manifestations in these patients are issues with balance. They do have bradykinesia, but that's symmetric on both sides. They're slow. The falls which take place in these patients, they are usually without any warnings. They don't have any aura or change in level of consciousness. And postural instability, as I said, is the first symptom of most of these patients. In contrast to idiopathic Parkinson's disease, in which postural instability occurs after a few years of the diagnosis and is not present in the beginning of the course of the disease. These patients do have spastic dysarthria, stiffness when they speak, and they also have issues with behavior. So behavioral issues include cognitive deficits and apathy and irritability, social isolation. And these patients usually don't have a tremor, except maybe 5% of the patients may have a very subtle resting tremor, and some about 10 to 15% of the patients may have a postural or action tremor. Again, that is also mild in amplitude. These patients do have facial hypomimia, but rather than blank faces, their facial expression are like astonished. They have a deepening of the nasolabial folds, deepening of the frontal folds, they widen the eye appearance, so they appear as to be astonished. And these patients do have trouble with their speech. They have a soft speech with hypophonia. They do have lead pipe rigidity, which we see in Parkinson's patients, but that lead pipe rigidity is uniform on both sides of the body. And other features which these patients have, and they may develop as the disease progresses, is axial rigidity. The rigidity in the Neck is more, usually it's more than their limbs. So they have axial rigidity, and that is disproportionate to their limb rigidity. And these patients do have an erect sort of posture. So, so rather than a stooping of posture, which we see in idiopathic Parkinson disease, they have a somewhat retroflex posture. Their posture is like a lordotic posture. So when you test their eye movements, they have a delayed initiation of SCOTs. So to start the SCOTs, if you tell them to shift between your finger and nose at a distance, so the initiation of SCOTs is slow. When you check up to kinetic nystagmus, so that is also shows the breakdown, especially in the vertical plane. The horizontal plane may remain intact initially, but the vertical plane is affected in most of these patients. With respect to the cognitive difficulties, these patients have a subcortical frontal type dementia, and as I said, they do have in maybe rare cases or severe cases, they could develop an opistotonic posture because of the retroflexion of their trunk, and they could develop a retrocollis rather than antrocollis, which we see in idiopathic Parkinson's disease. Swallowing problems also start usually in the beginning of the course of the disease. So, and in addition to this, these patients could have blepharospasm, and sometimes they have the apraxia of lid opening, which could be isolated or in combination with blepharospasm. Other problem with their eye findings is micro square wave jerks, which are a fixation artifact. And although these micro square wave jerks, they are not specific to progressive supranuclear palsy, and they could be seen in the other conditions. Because these patients also have the slow blinking, so their rate of blinking is also less. So these patients could have the inflammation of conjunctiva or the lid inflammation, and they could feel the dry eyes, and they may develop the blepharitis in some cases because of not blinking their eyes enough. And then frontal executive dysfunction is usually seen in the beginning of the course of these patients. They have especially trouble in the problem solving, sorting, the set shifting, abstract thinking, and judgment. The vertical gaze palsy is the most distinctive clinical feature. However, that may not be obvious in the beginning of the course of the disease. The most characteristic of the vertical gaze palsy is the impairment of the down gaze. So they have trouble looking down. The looking up could be a problem in other conditions, such as some patients with Parkinson's disease or other neurodegenerative conditions. They may have trouble looking up, but the patients with progressive supranuclear palsy, they have a characteristic gaze palsy of the down gaze. And therefore, because of the down gaze is required for reading or coming downstairs or looking down, so these patients may develop special difficulty in reading or looking down. Sometimes when they're eating, they may miss the food in front of them from the dish because they can't just look down. And also, when they come downstairs, they find it quite difficult because the downstairs coming requires the gaze to be down. The other feature in these patients could be an emotional incontinence, the pseudobulbar effect, which could be crying or laughing without any obvious reason. Usually in these patients, the autonomic dysfunction is not prominent, so dysautonomia may be absent in these patients. However, some of the manifestations, such as erectile dysfunction or constipation and urinary incontinence, could be found in these patients. As we discussed before, the supranuclear ophthalmoplegia is very common, but it may not develop till the late stages of the disease. And slowing of the SCOTs usually starts before the down gaze impairment. And as the disease progresses, these patients may lose the total gaze. So they may develop a complete ophthalmoplegia as the course of the disease progresses.
What are the pathological changes in the brain tissue itself in progressive supranuclear palsy?
This is a quite interesting question. It is much different than idiopathic Parkinson disease or multiple system atrophy, which are synucleinopathies. In this case, in case of progressive supranuclear palsy, there are neurofibrillary tangles, and these neurofibrillary tangles are deposited in different areas of brain, such as substantia nigra, striatum, globus pallidus, subthalamic nucleus, and superior and inferior colliculi, hippocampus, red nucleus, frontal part of cortex, or periaqueductal gray matter. Also, inferior olive and dentate nuclei may have these deposits, and some of the pontine nuclei. Now, these neurofibrillary tangles, they are made of tau proteins. So therefore, these are called the taupathies rather than the synucleinopathies. So they are the taupathies. Now, these tangles, they are deposited in certain areas as the cerebral cortex and nigrostriatal areas and the cholinergic nuclei. So these changes give these patients some typical features, such as deposition in the cerebral cortex causes the cognitive impairment and behavioral changes, and involvement of the nigrostriatopallidal area in these patients causes slowness or bradykinesia and rigidity. The involvement of the pontomesencephalic area causes the gaze palsies and sleep disturbances in these patients. So these patients have multiple neurotransmitter abnormalities, not just limited to the dopaminergic system. So in addition to dopaminergic deficit in the nigrostriatal pathway, these patients may have cholinergic damage in various areas, and also loss of the adrenoreceptors. The brain region which is most affected in these patients are the pigmented neurons in the zona compacta of the substantia nigra, and it is unlike Parkinson disease, which has asymmetrical damage. These patients have a symmetrical or a uniform damage, and therefore when you examine them, you check their finger tapping or opening and closing of hands, or maybe hand turns, so there is usually no asymmetry. So the movements are slow on both sides, they are uniformly slow. And indeed, the patients, when you check their slowness by walking or by other methods, they may appear more slow, and their finger tapping or opening and closing of hands or hand turning may not be as slow as they are overall slow. So sometimes if you check bradykinesia only by the repetitive movements of hands, they may be quite good. In these patients, the cholinergic PPN nucleus, the perenchylopontine nucleus, PPN, and the external pallidum are more severely affected, whereas the internal pallidum is much less severe affected.
Oh, very good. How is progressive supranuclear palsy diagnosed, and what are the big mimickers?
The diagnosis of progressive supranuclear palsy could be a challenge, especially in the initial stages, because as we discussed previously in previous hangouts, about 2/3 of patients with Parkinson's disease, they have a resting tremor or a tremor, and 1/3 of patients or 30% of patients may not have any tremor. So those patients who don't have a tremor and they have idiopathic Parkinson's disease, so with them, progressive supranuclear palsy can be easily confused. Patients with progressive supranuclear palsy, when they present initially, they are diffusely bradykinetic, symmetric bradykinesia, there is no tremor, so it and in the beginning, because they may not have the gaze problems or obvious trouble with speech or any major cognitive issues, so they may be difficult to differentiate. But as the disease progresses, it evolves into more features, and it declares itself. So the diagnostic criteria have been proposed for progressive supranuclear palsy, and experts divide them into the possible cases of progressive nuclear palsy and the probable cases. The definitive diagnosis, of course, requires the neuropathological studies. So most of these patients, with respect to diagnosis, their main features of their diagnostic criteria are that this is a generally progressive disorder and usually starts at the age of 40 or older, and it should not have the evidence of other competing diagnoses such as MSA or multiple system atrophy or corticobasal degeneration, CVD, or Lewy body disease or idiopathic Parkinson disease. And these patients, to have a probable PSP, they should have a gaze palsy, vertical gaze palsy, and slowing of the vertical scuds is also included in the criteria. And in addition, these patients have the prominent postural instability with the history of falls, usually in the first year of the case presentation. Then some of the features may help to exclude the diagnosis of progressive supranuclear palsy, such as if they have any recent encephalitis, or if they have alien-linked phenomena, or cortical sensory deficit, or maybe temporoparietal atrophy, because these type of features are more seen in corticobasal degeneration. If they have psychosis, that could also be going against the diagnosis of progressive supranuclear palsy. Cerebellar signs, dysautonomia, which is most in MSA, so that is also takes you against the diagnosis of progressive supranuclear palsy. If they have severe or asymmetric Parkinsonian signs, that would also not be characteristic of progressive supranuclear palsy. And if they have any structural abnormalities, such as basal ganglia stroke or any tumors, of course, that would not be consistent with progressive supranuclear palsy. And in some cases, a very rare condition, Whipple's disease, could be an excluding factor for progressive supranuclear palsy. As the progressive supranuclear palsy progresses, the signs and symptoms of patients would evolve and they would change. In the beginning, lots of studies have shown that the diagnostic errors or diagnostic challenges is very common. Sometimes misdiagnosis could happen, especially when there is a lack of the gaze palsy, or when there are other complicating symptoms such as hamide dystonia or early onset of dementia, or some patients when they have a obvious response to levodopa, that could take the physician away from the diagnosis of a progressive supranuclear palsy. Now, CT scan or MRI are usually not useful in idiopathic Parkinson disease. In case of progressive supranuclear palsy, although not always, in small number of cases, it could show some findings which may help us to support the diagnosis of progressive supranuclear palsy, such as they may have a reduced diameter of midbrain, or some signal changes in the midbrain. Sometimes the third ventricle is dilated, and the signal of the red nucleus, which is commonly seen, like normally seen, it could become more intense, and the frontal and temporal atrophy can be seen in these patients. So these findings in the early course of disease may not be very useful, but of course, if there are clinical findings and then these findings are seen, which are usually late in the course of disease, that can reassure the physician that he's working in the right direction. With respect to your question of what could mimic progressive supranuclear palsy, the conditions such as normal pressure hydrocephalus. These patients may have some cognitive issues. They may have urinary incontinence, and they may have issues with gait. So that could be sometimes confused. Myasthenia gravis, patients with myasthenia gravis could be, because they are weak diffusely, so they may look like they are slow. And so that could be that could be another condition to consider in the differential diagnosis. Then if there are tumors in the dorsal brainstem, they could cause some gaze issues. So that could be a condition. Other than SCA3, the spinocerebellar ataxia 3, Michel-Joseph disease, or Huntington disease, can sometimes, in early cases, could be a mimicking condition. In the early stages of progressive supranuclear palsy, the most common mimicking condition is idiopathic Parkinson's disease. The multi-infarct dementia could be a mimicking condition as well, because these patients may have some asymmetry, may have some of the pyramidal signs or vascular lesions. So you can use these to differentiate from progressive supranuclear palsy. The multiple system atrophy is another condition which could present with the diffuse bradykinesia. The findings are usually symmetrical, although they don't have eye movement abnormalities. Usually, they have more prominent dysautonomia and cerebellar findings. And in cases of MSA, multiple system atrophy, these patients usually have enterocollis, like their neck is bent forward rather than backward in patients with progressive supranuclear palsy. So these things can help to differentiate it from the progressive supranuclear palsy. The corticobasal degeneration is distinguished from progressive supranuclear palsy by its asymmetry. So corticobasal degeneration not only is asymmetrical at the onset, but it keeps it asymmetry throughout the course of the disease. Usually, idiopathic Parkinson's disease is asymmetrical at the onset, and as the disease progresses, these patients lose their asymmetry. So they involve the other side almost equally or very slight asymmetry. But in cases of corticobasal degeneration, the asymmetry is more pronounced, and it always remains throughout the course of the disease. So that could be a helpful feature to differentiate it from progressive supranuclear palsy. In addition, the patients with corticobasal degeneration, which is also another rare condition, they could have a myoclonus, especially stimulus-sensitive myoclonus. They could have prominent pyramidal sign. They could have sensory extinction. And these patients, however, patients with MSA or progressive supranuclear palsy, they all share the findings of or a lack of response to the dopaminergic medications, and a survival between 5 to 10 years, and the non-familial incidence. Another condition which could be confused is Lewy body dementia. The patients with Lewy body dementia, they early on, they could be sometime misdiagnosed as PSP, but patients with Lewy body dementia usually have a very prominent psychosis. They have visual hallucinations, which are very common. They have fluctuation in the level of consciousness, episodes of disorientation during the day, and these patients may have depression, which is more prominent than patients with progressive supranuclear palsy. And in a small number of Lewy body disease, these patients may have some response to levodopa, especially in the beginning. The small scale of bradykinesia or rigidity, which you may see in Lewy body dementia, that may respond to levodopa at times. So that could be you can use that as a differentiating factor from the progressive supranuclear palsy.
Yeah, you mentioned prior, early in the discussion, but how how is progressive supranuclear palsy or PSN different from idiopathic Parkinsonism disease?
I think this is the most important question of
Oh, thank you very much.
Today's discussion. The idiopathic Parkinson disease is the most commonly confusing diagnosis with progressive supranuclear palsy, and it's important to separate the two because of many reasons. The treatment response is much more in idiopathic Parkinson disease, then the prognosis of idiopathic Parkinson disease is better, and also the treatment expectation for the patients and the caregiver are very important to discuss in cases of progressive supranuclear palsy in contrast to idiopathic Parkinson disease. So we will take few of the important points, like with respect to age of onset. Although it has a wide range, but usually the idiopathic Parkinson disease is anywhere between 5th and 6th decade. Average age is between 55 to 60. And the progressive supranuclear palsy is between 6th to 7th decade, the age of onset. With respect to the presenting symptom, in case of progressive supranuclear palsy, the first and the most important and the initial presentation is falls without any warnings, postural instability, the gait disorder. Whereas in cases of idiopathic Parkinson's disease, the common presentations are bradykinesia and a resting tremor. And these patients with idiopathic Parkinson's disease, they develop postural instability after usually few years from the diagnosis of idiopathic Parkinson's disease. Usually a family history of progressive supranuclear palsy is absent. It's a sporadic condition. We have seen patients sometime that their first-degree relatives had a condition which was progressive supranuclear palsy or quite similar, because you may not end up seeing all family members. Some might have passed away before, but there are some reports. But usually family history in progressive supranuclear palsy is absent. In case of Parkinson's disease, the family history may or may not be present. So having a positive family history in a first-degree relative or close family members is more likely in case of idiopathic Parkinson's disease. With respect to posture, the posture in progressive supranuclear palsy is either straight or erect, or sometimes it's retrocaudus or lordotic posture. The posture in idiopathic Parkinson's disease is stoop. Their neck is bent forward, they are bent at their knees and hips, and sometimes at their neck as well. So the posture is quite opposite. Forward bending in idiopathic Parkinson's disease, and the backward bending or erect at least in case of progressive supranuclear palsy. With respect to cognitive dysfunction, the cognitive dysfunction usually appears early on in progressive supranuclear palsy, although it could be subcortical frontal nature. But in idiopathic Parkinson's disease, the cortical dysfunction is, the cognitive dysfunction comes on usually late in the course of disease. And even in those patients, the language and the praxis may remain intact to a good late stage. With respect to the gaze palsy, the down gaze palsy is common or the most characteristic feature of progressive supranuclear palsy. It may be present initially, or at least the slowing of scots and breakdown of the optokinetic nystagmus, but the down gaze palsy is usually absent in patients with idiopathic Parkinson's disease. Similarly, blepharospasm, although blepharospasm may occur in idiopathic Parkinson's disease, but the likelihood of having blepharospasm is much more common in progressive supranuclear palsy. And in cases of progressive supranuclear palsy, the ALO, apraxia flat opening, is much more common than idiopathic Parkinson's disease. And in our personal experience, with respect to treatment with botulinum toxin, the blepharospasm or ALO may be more resistant to treatment in cases of progressive nuclear palsy, whereas in case of idiopathic Parkinson's disease, it's more responsive to botulinum toxin treatment. In progressive supranuclear palsy, the blepharospasm and apraxia of lid opening could exist at one and the same time. The pseudobulbar effect, the emotional crying or emotional laughing, it's usually present in progressive supranuclear palsy, but it's usually absent in idiopathic Parkinson's disease. Then gait, with respect to gait, which could help to differentiate these two types of disease. So gait in case of progressive supranuclear palsy, so their feet are more wide apart. They are unsteady, they are wide base, and sometimes you may think that this looks like a cerebellar gait, whereas in case of idiopathic Parkinson's disease, these patients have a slow speed, they have a narrow base, and they have a short stride. They shuffle. They might have fascination, which is very much characteristic of idiopathic Parkinson's disease. You don't see fascination in progressive supranuclear palsy. Rigidity. The rigidity in supranuclear palsy is clearly more axial rigidity, and it's disproportionate to limb rigidity. Sometimes you find only very subtle rigidity in the limbs, but neck is quite rigid. So axial rigidity is much more in case of progressive supranuclear palsy as compared to rigidity in the limbs. Whereas in case of idiopathic Parkinson's disease, the limb rigidity is much more prominent, and axial rigidity may not be there in the beginning. It may develop as disease progresses, but usually the appendicular rigidity is, the rigidity in the limbs is more prominent than the neck rigidity. With respect to the facial expression, as we discussed before, the facial expressions in progressive supranuclear palsy, they are more deepened. They have very prominent nasolabial folds, deep frontal folds. The eyes are wide open. They appear as astonished. Whereas in case of Parkinson's disease, their facial appearance is more flat, masking of faces. They don't have the deeper expressions. And so in both types, the rate of blinking is also reduced. With respect to the resting tremor, the resting tremor is usually seen in about 2/3 of patients with Parkinson's disease, although it could be subtle, just involving index finger or a thumb or just the hand in the beginning. But resting tremor is usually absent in progressive supranuclear palsy. In about maybe 5% of patients, you might see at some stage of disease a very subtle resting tremor, which does not last longer, and it may resolve. It may disappear with time. So resting tremor could be a very reassuring sign in case of Parkinson's disease that you can differentiate it easily. With respect to corticobulbospinal signs, they may or may not be present in case of progressive supranuclear palsy, but they're usually absent in idiopathic Parkinson's disease. The symmetry remains a very clear sign. You can just see patient walking, and you can have a good idea about differentiating them from progressive supranuclear palsy and idiopathic Parkinson's disease. The idiopathic Parkinson's disease is asymmetrical, especially in the beginning. If patient is presenting early on, it's quite asymmetrical. It could be unilateral in stage 1, Hohen and Yahr stage 1, could be only one side. And as disease progresses, it stays asymmetrical, but these patients may lose asymmetry. But in case of progressive supranuclear palsy, it is symmetrical. The findings would be same. The slowness, the rigidity, they would be same on both sides of the body. With respect to response to levodopa or dopaminergic medications, these patients with progressive supranuclear palsy, they may not respond. Usually, they don't respond, or they respond only partially. Very light response to levodopa, whereas idiopathic Parkinson's disease, these patients always respond to levodopa, and the response to levodopa is taken by some experts as a reassurance or a diagnostic sign that these patients have idiopathic Parkinson's disease. The one other feature which we usually don't see in progressive supranuclear palsy is hallucinations, like visual hallucinations. They would be much less common if happen in progressive supranuclear palsy, but they would be more prominent in idiopathic Parkinson's disease, although they occur a bit later in the stage of disease. Similarly, hyposmia or anosmia would be seen in idiopathic Parkinson's disease, or would be much more common and usually would be absent in progressive supranuclear palsy, or they would be very partial. The levodopa-induced dyskinesias, which are the rocking movement, coliform movement, which start after a few years of use of levodopa. They're common in Parkinson's disease patients, so you don't see in most progressive supranuclear palsies. There have been some reports of dyskinesias in progressive supranuclear palsy and multiple system atrophy, but usually they are very rare. The dyskinesias are commonly seen in late-stage idiopathic Parkinson's disease.
What are the treatment options in progressive supranuclear palsy?
This is a very, unfortunately, it's a very disappointing part of this discussion.
Okay.
First of all, there's no cure, as it's a neurodegenerative disease. The patients usually respond only partially to dopaminergic medications. So with respect to levodopa, the response is much more subtle, or some patients may not notice much response, especially with the lower doses, with which the patients with idiopathic Parkinson's disease would report a very significant and robust response. But in case of progressive supranuclear palsy, you may have to go at a much higher dose to see even a partial and mild response in these patients. You may have to go up to maybe 1,500 milligram of levodopa quite early on in the course of the disease to notice some of the response or improvement in these patients. The behavioral side effects as a result of levodopa, which you can see easily in patients with idiopathic Parkinson's disease, or more commonly, you would not see in cases of progressive supranuclear palsy. In some of the studies, amantadine has been tried. Amantadine may be used in idiopathic Parkinson's disease, usually for tremor, or in the stages of disease for dyskinesias. But same amantadine could be helpful slightly in cases of progressive supranuclear palsy. Some experts report that the speech of patient may have some improvement, and however, the dosage usually in progressive supranuclear palsy is up to 200. So most physicians would not go above 100 milligram twice a day, and because of its anticholinergic effect, so sometimes it could cause cognitive difficulties requiring stopping of amantadine. And amitriptyline has been used in some patients with progressive supranuclear palsy, and there could be some improvement, partial improvement, especially in the beginning, to the gait as well as rigidity. And if these patients have depression, probably that could help depression as well. However, the dosage of amitriptyline, which has been tried by most people, is twice a day. Usually, amitriptyline is usually it's a once-a-day drug because it's a long-acting drug. But usually 10 milligram twice a day at bedtime and in the morning may be tried, and some patients may feel helpful to the rigidity and gait as well as depression. But most physicians would not go higher than 20 milligram in cases of progressive supranuclear palsy. And then with respect to blepharospasm and the apraxia of eyelid opening, the botulinum toxin treatment is helpful, although it may require higher doses. And sometimes, even at much higher doses, you may see only a very limited response. And if these patients unfortunately have apraxia, fluid opening, and blepharospasm, then you may need partial myomectomy in addition to the botulinum toxin treatment to get some response. Because blepharospasm is such a condition which can make you functionally blind. You may not be able to read, you may not be able to watch TV and come out of the house because of the sun and wind blowing. It may lead to shutting of the eyes. So it needs to be treated in many patients. Some reports have suggested that the retrocollis or the torticollis in these patients, the backward posturing, may be helpful with botulinum toxin, but I think the experience is limited, and because of the injections in the neck, so these patients already have some difficulty with swallowing, so this could lead to dysphagia and then aspiration pneumonia in these patients. Some of the experts report anticholinergic, the peripherally acting anticholinergic medications. They could help the urinary incontinence in progressive supranuclear palsy. Some physicians use baclofen as well for the dystonia, the symmetric dystonic posturing, and sometimes the antidepressants or sedative medications could be used at the time of going to bed that could help with the sleep. Physiotherapy, although has a very limited benefit in these patients, but physiotherapists probably could teach these patients techniques to watch their balance and avoid falls. They could also adjust the height of the walker. They could also guide them what type of walker, whether they should have a four-wheel walker, two-wheel, or walker without any wheels. So physiotherapists are quite experts in this field. And once you start seeing them, then another benefit is that you are involved in a regular exercise program. Speech pathologists may help, not only in terms of speech, at least a short-term benefit, but also guide them swallowing issues, and they may help patients to guide some speech augmentation devices, such as electronic typewriters or devices which you type and they would speak for you. So they could also teach patients to flex the neck when swallowing, swallow twice or multiple times to help the swallowing. The falls, as we discussed, remain an important issue in these patients. And the falls could be quite serious. They could lead to fractures, they could lead to intracranial hemorrhage, and they may require hospitalization. So it's very important to teach these patients to prevent falls. So fall prevention strategies, I think, are one of the main goals of treatment of these patients. They should be taught, the caregivers should be taught, and they should be emphasized to use a walker and all the other techniques of gradual rising, slow turning, and use of a heavy walker. The canes usually don't help. When the patient falls, the cane falls with them. And also, in some cases, with the early presentation, when the features of progressive supranuclear palsy are not very prominent, and these patients present with falls, so I think you should rule out any other causes such as cardiac arrhythmias and arthritis, postural hypotension, visual impairment, or sometimes the benzodiazepines taken at night time could make patients foggy, and they could fall during the day. The focal weakness or peripheral neuropathy, normal pressure, hydrocephalus, vertigo. Vertigo is another condition. Patients could fall, seizures, and freezing of gait. So these things could lead to falls early on when the diagnosis is not quite clear. I think all causes of falls could be excluded. Some of them can be excluded easily based on history and physical examination, and some may require investigation such as a Holter monitor or EEG and other studies. In addition to this, it's very important to emphasize patients to have a well-fitted footwear. The shoes has to be really good. The leather-soled shoes, especially if you live in Canada, you should have a good ice grip because that would help you to avoid slipping. Females should avoid the high heels because they are a risk for falls. And patients in their home, patients should have a OT, occupational therapist, to come home and assess safety. There should be enough lighting in the hallways, in the staircase, and there should be handrails in all the walkways. And also patients, as I said, they should keep the walker at night time close to their bed, because when they rise from supine position, they should wait, and then when they are ready to stand up, they should hold walker, because if the caregiver is sleeping, no one is there to help. There is a time when a lot of falls take place in these patients. Keeping the outdoor steps free of ice in good condition is very important. They should be stable. They can take the weight. They should not be shaking. And also carpeted flooring is better than the small rugs, because patients can trip over easily. Not having pets, they could lead to falls. Having phone on every floor of the house, we emphasize all the time to the patients. Having a phone without a wire. Also the arm bracelets could help. And safety assessment, as I was discussing, it should involve the bathroom safety as well. The OT usually assesses the bathroom, and they do install the handrails and non-slip bathtubs, the floor mats and bath benches, and all these things should be non-slip. Patients should sit down when they're changing their clothes, dressing or undressing. They should not lock the bathroom doors from inside in case the falls take place. The caregiver or someone in the house can come in easily. And it's best for patients if they have someone accompanied with them. In case if they fall, they should lie down on their back. They should try to swing on their side. Then they should try to bring their hands and help their hands to get up into at least in a sitting position, or they should slowly crawl towards the nearest object. And the furniture should be heavy enough so that if they can put their hands on it, it could take their weight and help them to stand up. Then the first thing they should do after this position, they should try to bring their good leg up so their knee is close to chest, and they should try to push their body, taking the support of their leg to stand up, and that could help them to get into an arising position. The swallowing problems, unfortunately, remain a major issue in these patients. They could lead to aspiration, and aspiration is one of the major cause of death in these patients, unfortunately. So swallowing studies should be done early on in these patients. They should plan a longer time to finish their meals, chewing their food slowly, sipping liquids in between is helpful. The food should not be hot, and soft foods like jellos, yogurt, applesauce, they're very helpful. And when they're swallowing, during eating, they should try to swallow each morsel twice, and they may try to bring their chin forward and bend forward. That helps. Taking small morsels of food is helpful in these patients. And also they should have the assessment by a speech swallowing pathologist, and you may need the assessment more than once. They may need to see them in the beginning of the course of the disease, and then as disease progresses, they may need to see them again. Unfortunately, none of the pharmacological medications or pharmacological treatments are very much successful for the swallowing treatment or swallowing problems. There has been some reports of anticholinergic medications causing some improvement, but at the same time, they could lead to worsening of dysphagia. Some people have tried the botulinum toxin injections in the cricopharyngeal muscles. They might be successful only in a minority of patients. Most patients, unfortunately, they end up being bed-bound, and they may need the gastrostomy tube to feed.
Okay, very good. That's a pretty good overview of progressive supranuclear palsy. Is there anything else that you can think of to add before we close, Dr. Rana?
I think the important point in these patients is for a person, a student, or a beginner. I'm still a student of movement disorders and neurology, and I do find sometimes difficulties in differentiating these patients. I think in the beginning of the course of the disease, it's very important not to give a verdict on the first appointment or give a definite answer if you are not sure, unless patients are in a bit advanced stage or they have gaze palsy or they have a very characteristic feature you are convinced. So I think you may have to see these patients maybe a couple of times. And although it's very important to give diagnosis, because some of these patients might have seen more than one neurologist before they would be referred to a movement disorder center or a clinic. So they come with expectations, but I think taking time, assessing them thoroughly, and then spelling out the diagnosis once you are sure is better rather than rushing, because if you make a mistake and patients and their caregivers, unfortunately, they would be disappointed, and they could the progressive supranuclear palsy. Once you go online or search the web, it's quite a disappointing diagnosis. So I think you should be careful till a person is sure, and also the treatment expectation and prognosis, because it's not good. So I think this should be kept in mind when you are assessing these patients.
Very good. Okay, Dr. Rana, that closes it for progressive supranuclear palsy. This can be seen on Parkinsonism.tv, as well as the other educational Parkinsonism videos. And tomorrow night, what topic are we covering, Dr. Rana?
We'll decide tomorrow.
Oh, okay. Okay, I thought we were going to do the second one. Okay, whatever. Okay, thank you very much, Dr. Rana. Good night.
You're welcome. Thank you.